Thank you, Sripriya. And yes, we are on the last session. It's been a wonderful journey with you all. For the last session, we have Dr. Sunil. We've already heard from Dr. Sunil about opioids. So today we'll be dealing in detail about methadone, as it is a comparatively newer drug in the country, and there are very, very few centers which uses methadone, and Pallium uses that as routine for last few years. And so it will be good to hear from Dr. Sunil, because how we started, what all hurdles we had in the beginning, and how we learned from practical experience than from combined with the textbook knowledge. So he'll be discussing that everything in detail. Welcome, Dr. Sunil. I'm not introducing you again because you already met this group once before. Over to you, Dr. Sunil.
Thank you, Sridevi. Good afternoon, everybody. Am I audible?
Yes, sir.
Okay. So I have a very bad cold. So
maybe you can keep your microphone a little closer. That's it.
So I'll be switching off my video because my bandwidth is also very poor. So I will start by sharing the screen. Okay, so methadone was actually a new opioid which was introduced into Indian market in 2018. But even before that, methadone was available in India, but as an opioid for substitution therapy for those who are dependent on other opioids. So it was available previously, even before 2018. But from 2018, it is available to use as an analgesic. Okay, so some of you might have heard about many things about methadone. Until and unless you use it, you will not be able to understand it correctly. So when I hear the word methadone for the first time, I had many fears and concerns. But during the course of 3-4 years of use, now we are confident to use methadone. So we'll be talking about pharmacology of methadone because it is different from other opioids. Always when you talk about methadone, you will be hearing many bad things about methadone. But there are benefits also. So we will see the benefits and what is the risk-benefit ratio of using methadone. And another thing would be when a patient is on methadone, how are we going to monitor the patient? And when I started teaching on methadone, I came across many questions, and even after finishing the course, I know one institution who bought 3 bottles of methadone, but they were unable to use it because they couldn't find out an appropriate patient. So I think that's also important. And how will you convert when a patient is on another opioid? Because there are numerous methods available if you look at the net. But we will go through only one method, which is the simplest and the newest method. So let's go into the pharmacology of methadone. Methadone is an isomer of R-methadone and S-methadone. Opioids acts on opioid receptors, and mu, kappa, and delta are opioid receptors. Mu, morphine, fentanyl, and many other opioids are mu agonist. But methadone is agonist on all the receptors, mu, kappa, and delta. And from the literature, it says it has NMDA and agonistic activity. So, can anybody tell me which is the other medication which has which can act as an NMDA and agonist? Anybody?
So there are a few chats, ketamine.
Okay. I think, Sophia, I think we forgot to show the polls first. So I think now we can show the polls and then we will continue. So first we have some questions which Sophia will show you. You have to select the best answer and submit it. This will not be counted for any of your assessment. This is just for you to assess yourself on what is the knowledge that you have about methadone.
Okay, sir. Launching the poll now. The poll will be having 2 sessions, poll 1 and poll 2. Poll 1 will be having 6 questions and poll 2 will be having 9 questions. So, sir, with your permission, we are launching the poll 1.
So we were talking about pharmacology of methadone, and we already told that the methadone acts on all the opioid receptors, and it has another additional action on NMDA receptors and acts as an NMDA antagonist. And some of you told that ketamine is another NMDA antagonist, which is useful to manage pain. And then it has another action. It inhibits reuptake of noradrenaline and serotonin. So, which are the other group of medication which acts like this mechanism? Anybody please unmute and tell. Which are the other group of medication which inhibits the reuptake of noradrenaline and serotonin?
There is one response which is TCA.
Yeah, tricyclic antidepressants. That's true. So these are 3 mechanisms of action which are actually beneficial in managing pain. But there is another mechanism of action on human either ago related gene. That is what in short form HERG. And this HERG gene is seen in smooth muscles and most abundant in the myocardium. So when it blocks HERG gene, it causes something called as torsades de pointes. All of you know that some medications can cause torsades de pointes and can cause sudden death. So this is one of the negative side of the methadone. But we have to talk about this. We'll talk later. So let's see what are the clinical impact due to different mechanism of action. So it is an opioid receptor agonist on all opioid receptors. So it will have analgesic effect. But because of the same action on the receptor, it has side effects also. So it can produce the usual opioid side effects like constipation, nausea, retention, pruritus, etc. Then we told that it acts as an NMDA antagonist. So you can see in the graph, there are 4 patients, A, B, C, and D, and they are taking thousands of milligrams of morphine per day. The first patient D is taking about 1000 milligram. C is taking 2000 milligram. B is taking about 8,000 milligram of morphine, and A about 12,000 milligram of morphine per day. Uh, if you can think about, there are patients who are taking this much large doses of morphine. There is another word which I have introduced here, tolerance. So can anybody tell me what is tolerance? What is tolerance? Anybody?
There are few responses over time.
Yeah.
Higher doses drug not having effect worth the same when same dose of opioid fails to produce desired analgesia.
Yeah, that's correct. So, suppose a patient is taking 10 milligram of morphine today to get a pain relief. His pain score becomes 4 by 10. Maybe after 2 weeks, the patient needs to take 20 milligram of morphine to get a pain relief of 4 by 10. And after some time, this will go on increasing. Maybe after 2 months, it may go up or go on to 200 milligram of morphine to get the pain relief 4 by 10. So to get the same effect, you have to increase the dose of that drug, which is known as tolerance. Okay. So in case of tolerance, NMDA receptor is one of the mechanism which is implicated. So as methadone is an NMDA antagonist, actually, even though these 4 patients are various doses are on various doses of morphine, you can straight away start on methadone at a particular dose, and all of them can have pain relief. So this is what is indicated in the next slide. So all these patients were started on 10 milligram of methadone every 8 hours. That means 30 milligram of methadone every 8 hours. 30 milligram of methadone total, and all of the patients had very good pain relief. This the explanation is that this is because NMDA receptor is involved in the mechanism of tolerance, and as methadone is an NMDA antagonist, it gives or prevent and bring back the tolerance. So this is another action of methadone. And you know that tricyclic antidepressants are adjuncts which are used to treat neuropathic pain. So methadone is also acts by the same mechanism. So it has an additional advantage in treating neuropathic pain. But it can also produce something called as serotonin syndrome. And if you use methadone with other medications, which also inhibits the reuptake of serotonin, it can increase the levels of serotonin and produces a syndrome called serotonin syndrome. You can see many of the drugs, SSRIs and many other antidepressants, which if used along with methadone, can cause serotonin syndrome. And there are many signs and symptoms of serotonin syndrome. It can occur in 3 domains. Cognitive changes can occur, autonomic instability, and neuromuscular changes. If a patient is agitated and it has hyperthermia, and if there is tremor, and if the patient is on methadone, just think whether is it due to serotonin syndrome. This patient is also taking some other medication which also inhibits the reuptake of serotonin, like acetylopram or citalopram, something like that. So this is a syndrome which has been described in literature. I haven't seen any patient with serotonin syndrome. So we already told that methadone can be used as a substitution therapy in opioid use disorder. But it's also used in pain management, and these are some indications in which we have to use methadone if a patient needs a long-acting medication. Then methadone would be useful because its mechanism, its duration of action is about 8 to 12 hours. So either you have to give it 8 hours or 12 hours. And methadone is supposed to be safe in renal failure. And we already saw that because of the action on NMDA receptor as well as the tricyclic-like action, it is useful to treat neuropathic pain. And we also saw that it is useful in preventing and reversing the tolerance. And it is also useful to treat hyperalgesia. So very rarely opioids can produce syndrome called hyperalgesia. Hyperalgesia is actually manifested like this. When a patient is on a fixed dose of opioid, the patient have pain with it. After some time, the patient's pain increases. You start increasing the dose of morphine, but increasing the dose of morphine, it actually worsens the pain, and pain will be more widespread. There will be allodynia, hyperalgesia, etc. So, which is known as opioid-induced hyperalgesia. And we know that opioids can cause some neurotoxicities. So that's another indication. And there are very rare patients who are allergic, truly allergic to other opioids. In such condition also, we can use methadone. The adverse effect, which we already know, that all opioids can produce constipation, nausea, vomiting, sleepiness, pruritus, urinary retention, etc. But the most serious condition that can be produced by the use of methadone are causative points, which can cause sudden death. And another one is serotonin syndrome. So let's move on to pharmacokinetics. Morphine is like morphine, methadone is also absorbed from the upper small intestine. But compared to morphine, the bioavailability of methadone is 80%. So what is the bioavailability of morphine? Can anybody tell me? Bioavailability of morphine. Anybody? Yeah, Dr. Bikram says 30%. Yeah, 20 to 30% is the bioavailability of morphine. But here, methadone is 80%. And when we talk about morphine, I think I have stressed that morphine should not be administered sublingually because it is not absorbed properly through sublingual route. But methadone can be absorbed sublingually and correctly also. In India, we have only oral preparation, but Western countries, they have injectable morphine also. After administration of methadone, what happens is that for a few hours, 2 to 4 hours, it will be seen in the plasma. That is for about 2 to 4 hours, which is known as a rapid alpha phase. And after that, it will immediately go into the tissue binding sites. And main tissue binding sites are brain, GIT, kidney, liver, muscles, and lung. And methadone will bind with within the cells. So there will not be any methadone for action when you start methadone for the first time. So this process will continue. That means the process of binding the methadone in the tissue binding sites will continue for about 5 to 7 days. After 5 to 7 days, this tissue binding sites get saturated, and then some fraction of methadone will be liberated into the systemic circulation, and that small fraction or free fraction will give you pain relief. Okay. So for free fraction or the tissue binding saturation occurs only after 5 to 7 days. So that means we have to wait for 5 to 7 days to get proper pain relief with methadone when you start for the first time. So it is unlike morphine. We can increase the dose of morphine every 24 hours. But in case of methadone, you have to wait for about 5 to 7 days before you increase the dose of methadone. So that is one of the most important things you have to keep in your mind. But in some patients who are elderly or patients with liver failure, severe liver failure, it may even take more days to have sustained blood levels. So it will take about maybe even 2 weeks. So maybe 5 days to 2 weeks is the time period which is required for the methadone to stabilize the blood level. But usually after 5 to 7 days, you can increase the dose. And the metabolism of methadone occurs mainly in liver. And there are many cytochrome P enzymes involved in the metabolism of methadone. You can see cytochrome P2B6, 3A4, 2B6, 2C19, and many others. So the importance is that many drugs will be metabolized by the liver. So because methadone is metabolized by many cytochrome P enzymes, there is a chance of having more drug interaction. So that's what you need to be careful. There are many drugs which can actually interact with methadone. Almost all the drugs which we use in palliative care, like benzodiazepines, SSRIs, haloperidol, fluconazole, ciprofloxacin, azithromycin, fluoroquinolones, all fluoroquinolones, macrolides, many drugs can actually interact with methadone. So that is one of the important things which we need to keep in our mind. And we told that one of the main feared effect of morphine is toxodepoils. And these are some risk factors to develop toxodepoils. Electrolyte abnormalities, that is hypokalemia, hypomagnesemia, and hypocalcemia. So calcium, potassium, and magnesium. These are the 3 electrolytes which we need to keep under radar. And increasing age, female gender, there are some genetic predisposition, and QTC, that is corrected QT interval, more than for 50 milliseconds. And when the dose of methadone increases, there is a chance of increasing the chance of getting toxodepoils. So how will you monitor or what are the investigations that you have to do when the patient is on methadone? So first and foremost is when we start a patient on methadone, we have to think what is the goal of care of this patient. So suppose this patient is the goal of care is only comfort care, then we need not do much investigation. But if the patient is having a curative intervention or palliative oncological intervention is going on, then we have to actually monitor the patient carefully. So what are the things we need to monitor? We need to get a baseline ECG. And this is for monitoring corrected QT interval. then calcium, potassium, and magnesium. Then you need to repeat ECG after 2 to 4 weeks of initiation of methadone. And then once the dose of methadone reaches 30 to 40 milligram per day and 100 milligram per day. But it is very rare to see that methadone for pain relief is going up to 100 milligram per day. Usually the doses which we use for pain relief is less than 40 milligram per day. And I already told you that we have to wait for 5 to 7 days before we increase the dose of methadone, because that's the time period required for the methadone for a steady state. Okay, so ECG, calcium, potassium, magnesium, these are the 2 important investigations which you have to keep in your mind, in addition to drug interactions. So we told that methadone can produce torsodipoids, but these the facts about torsodipoids has mostly come from the studies on patients who are using methadone as a substitution therapy. So usually these patients will be taking hundreds of milligrams of methadone. So when patients are using a higher amount of methadone, there is a chance of producing torsodipoids. But here, this is a study conducted by MD Anderson Cancer Center, where they started methadone in about 100 patients, and they followed up patients with ECGs at the starting, then 2 weeks, 4 weeks, and 8 weeks. And they found out that there were no serious events like torsodipoids or ventricular fibrillation. And all these patients were given less than 40 milligrams of methadone. So this is one study which we can indicate to tell others that this is methadone is usually safe if it is used carefully and within the maybe at a smaller dose. And I told you there are many drug interactions which can either increase or decrease the level of methadone. So there are many cytochrome P inhibitors. So you can note the acronym GPAC-MAN. G is for grapefruit. What is grapefruit? It is not grapes. It is something like citrus fruit. I think it is not available in India. And protease inhibitors, which are antiretroviral medications, as well as antifungals like fluconazole, ketoconazole, etc. Cyclosporin, macrolide antibiotics, amiodarone, and non-dihydropyridine calcium channel blockers, that is verapamil and diltiazem. So when you administer methadone to a patient who is already on this medication, there's a chance that the level of methadone can be increased because of a cytochrome P inhibition. So in such instances, you can reduce the dose of methadone by 25%. So likewise, there are cytochrome P inducers, and acronym is PS4. Phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, carbamazepine, St. John's wort. So when methadone is given along with cytochrome P inducers, the dose of methadone or the level of methadone in the blood will be decreased. But usually you need not do any intervention, just wait and watch for any reduced pain relief. And if the patient has less pain relief, then you have to increase the dose of methadone. So what you have to understand is there are many drugs which can interact with methadone, and this is I have given only a few examples. There is a long list of medications which can actually interact with methadone. So whenever possible, you avoid using strong inducers or strong inhibitors, which I have given here. So let's move on to the patients who will get or who are the good candidates for starting methadone. So methadone is used as an adjunct. So when you hear it is used as an adjunct, um, I, I think here the word adjunct is little misnomer, because you know that in the WHO analgesic ladder, adjunct is a medication whose primary aim is not pain relief, but is helpful in some painful condition. That is the definition of adjunct. So if you look at that way, methadone is not an adjunct, but why it is described as an adjunct is that when some patients, suppose the patient is on morphine, that patient has a very good pain relief during morning hours, but he had to wake up at night due to pain. And in such instances, if you give a small dose of methadone at night only, then that patient will have good pain relief and there will not be any need to wake up the patient at night. So in such instances, when you use methadone in a small dose, literature describes it as an adjunct. Okay, so please don't get confused the adjunct in WHO analgesic ladder and the use of adjunct here in case of methadone. So that's one indication. And pain refractory to other opioids. We know that there are some patients whom we see that with morphine or fentanyl or any other opioids, pain does not come down to the satisfactory level. In such a situation, you have to use a methadone. And if the patient has significant renal impairment, then methadone can be used, because methadone is mostly eliminated through bowel. And we know that methadone acts for 8 to 12 hours. So that's another indication to start methadone. And suppose the patient is on high dose of any other opioid, then methadone would be a choice. We already saw that patients who were on thousands of milligrams of morphine, when started on 30 milligrams of methadone, their pain came down. So high opioid tolerance. And if the patient has any toxic effects with other opioids, and room opioid allergies. So these are the indications to start a patient on methadone. And these are the inappropriate candidates for starting methadone. Family history of sudden death, sudden unexplained death, because there are congenital QT syndrome which can run in families. So if there is a history of sudden unexplained death in the family, so maybe it is due to congenital QT syndrome. So they are not appropriate candidates. And the QTC, corrected QT interval more than 500 milliseconds. And if the patient has poor cognitive function and is living without a reliable caregiver, then he is not a suitable candidate. So if the patient doesn't have a reliable caregiver, don't start patient on methadone. It is not like morphine. So when you give morphine, the effect can be seen after maybe maximum by 24 hours. But in case of methadone, you will start administering the wrong dose for 5 to 7 days. And then all of a sudden, after 7 days, the patient will have various complications, which will be very difficult to reverse. So if there is no reliable caregiver, it's an indication not to start methadone. And if you are unable to follow up the patient, don't start. If the patient is already on other opioids which are misused, like cocaine, amphetamine, etc. And methadone is not a good drug if the patient has acute pain crisis, because we know that it will take 5 to 7 days to act for proper pain relief. So these are the conditions in which methadone is not good to use. So these are the two preparations available in India. It's tablet and syrup. These are 5 milligram tablets and 5 milligram per 1 ml syrup. But as of now, only syrup is available, tablet is not available. So let's move on to methadone conversion. How will we convert a patient from another opioid to methadone? So first and foremost is a methadone does not have a linear conversion ratio. That means in case of other opioids, tramadol, fentanyl, or tapentadol, we can say that it is this much potent compared to morphine. If it is tramadol, we can say it is 1 by 10 as potent as morphine. But in case of methadone, you will not be able to say like that because at different levels of morphine, the potency of methadone varies. So it doesn't have a linear conversion. So this is the conversion ratio which we can use. This is the newest conversion method from consensus white paper by hospice and palliative care physicians. So if you are using methadone in an opioid naive patient, then opioid naive is considered as if the patient is taking less than 60 milligram of oral morphine per day, is considered as opioid naive. Then the dose which we can use is 2 milligram to 7.5 milligram per day. And if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if the patient is less than 65 years old, the conversion ratio is 10:1. That means 10 milligram of morphine will be equivalent to 1 milligram of methadone. And if the patient is taking more than 200 milligram of oral morphine, or the patient is more than 65 years old, the conversion ratio is 20:1. But whatever be the dose of opioid the patient is on, suppose the patient is on 1000 milligram of morphine, then if you look at the conversion ratio, it will be 20:1. That means 1000 divided by 20, that will come to 50 milligram. But never start patient on 50 milligram. Maybe you can start with 10 milligram TID. Probably that patient will have good pain. So we know that it might be due to tolerance. And how can you increase the dose of methadone? So methadone can increase only after 5 to 7 days in people with normal liver function. And that also, if the patient is taking less than 30 milligram of methadone per day, you can increase 5 milligram of methadone and wait for a week to increase further. And if the patient is taking more than 30 milligram, increase by 10 milligram and wait for 1 week to increase. But in case of hepatic impairment, or if the patient is elderly, which I already told you, wait for more days, maybe even up to 2 weeks. So now we will move on to some patient stories to see how we can convert that into methadone. So this is a 37-year-old man who had a carcinoma of the buccal mucosa in 2018. And then he was diagnosed with another primary papillary carcinoma of the thyroid, and he underwent surgery and radiation. Yeah, but in 2019, he had level 2 normal recurrence, for which he underwent surgery. But his main problem was very severe pain. You can see the patient is sitting. It's a very severe pain. It starts inside left ear, going back to head, then to submental region. He described it as pricking pain, and it is always 10/10. So, considering this pain, the treating team, the pain specialist did an extraoral mandibular nerve block 3 times, but there was no pain relief. And then they tried him on injection morphine, and patient had delirium myoclonus and drowsiness. Then they started patient like on oral morphine like this, 10, 15, 10, 30, and 10 milligram as twice. Even with this dose, the patient had a morphine toxicity. And they also used various adjuvants, but there were no pain relief. So these are the medications when the patient came to us. Tab morphine, 10, 10, 15, 10, 30. Pantoprazole, ciprofloxacin, citalopram, serratiopeptidase, diclofenac packs 1 every day. Tab paracetamol 650 milligram 1 hours. So can we start this patient on methadone? Anybody?
There is a response. Dr. Jennifer says yes.
After stopping escitalopram.
Okay, very good.
There is a question. Dr. Bikram is asking any feature of OIN.
Any feature of
OIN. Dr. Bikram, is it opioid induced?
neurotoxicity?
And there is another question. Why don't we increase the dose of morphine?
So I already told you that with tab morphine and with this dose 10, 15, 10, 30, the patient has opioid neurotoxicity. So we will not be able to increase the dose of methadone because it is going to produce more harm to the patient. If you look at the patient, is there an indication to start methadone? And if yes, what are the indications? Anybody?
Opioid toxicity.
Opioid toxicity. Yeah. Any other indications?
Inadequate pain relief.
Yeah, inadequate pain relief. Yeah. Anything else?
Around the clock pain not controlled by morphine and other drugs, and opioid induced neurotoxicity is an indication. Neuropathic pain.
Yeah. So I think complex neuropathic pain is one, and the other one is morphine toxicity, and as you told, inadequate pain relief. That is another one. So before starting methadone, what all will you ask to this patient? You actually wanted to start methadone for this patient. So what are the things you need to ask to the patient and to the family?
So ECG, cardiac problems, responsible
Okay.
caregiver.
Yeah. Yeah. So you have to ask about history of sudden unexplained death in the family. Then is there a reliable caregiver? Because these are two important factors which we have to ask before prescribing methadone. And as you told, ECG. Do you have any concerns with present medications? Any concerns with present medications? So these are the medications.
Escitalopram is one response.
Okay. So these are the medications. Okay. So escitalopram is
Ciprofloxacin.
ciprofloxacin. Fluoroquinolones is another group of medication which can interact, and pantoprazole also. So these are the three medications which we need to be careful while we prescribe methadone in this patient. So you decided that you are going to start methadone in this patient. So how do you calculate the dose of methadone? So this patient was taking 65 milligram of oral morphine per day. Okay. MBDD means morphine equivalent daily dose. It is same as oral morphine equivalent. Okay, OME. So 65 milligram. And this patient is 39 years. And oral morphine equivalent is between 60 to 199 milligram. So the conversion ratio is 1/10. So the total dose of methadone required would be 6.5 milligrams. So when you give 6.5 milligrams, you can give either tablet. If it is tablet, maybe 2.5 milligram BD can be given. That is 5 milligram. But if it is syrup, you can give 3 milligram daily. But we have to continue morphine on a SOS basis. That is Q4H SOS basis. We know that methadone will take about 5 to 7 days to give good pain. So till that time, we have to continue morphine on a Q4H SOS basis. When you give morphine only to the patient, you write the prescription as 10 milligram Q4H and SOS. It is there is and SOS. 1 minute. So 10 milligram Q4H and SOS means the patient need to take morphine every 4 hourly, and they can also take SOS doses in between. But here it is not 10 milligram Q4H and SOS. Instead, it is 10 milligram Q4H SOS. So that means at 6 a.m. you will administer methadone 2.5 milligram, and you will ask the patient, do you have pain? Suppose the patient says, I don't have any pain. You will not give morphine at that time. At 10 o'clock, you will ask the patient again, do you have pain? Patient says, yes, I have. Then you will give another 10 milligram of morphine. Then this will you will continue to ask to 6 and 10 p.m. And if they have pain, you will give morphine, otherwise you will not. That's what 10 milligram Q4H means. So in this patient case, the prescription should be like this. Syrup or tab, if it is tab methadone, 2.5 milligram daily, and if it is syrup, it should be 3 milligram daily. Morphine 10 milligram Q4H SOS. Tab paracetamol 750 milligram 6 hours. Instead of ciprofloxacin, amoxicillin should be okay, which doesn't have interaction with ethanol. Okay. So we have to stop escitalopram because this patient, they started the patient on escitalopram thinking that this patient has clinical depression, but the patient didn't have a clinical depression. It was because of pain. So we stopped escitalopram. Pantoprazole was actually not needed, so we did not continue pantoprazole. And which was the other one? Ciprofloxacin. So instead of ciprofloxacin, we substituted with amoxicillin. Okay. So this patient was started on 3-9 with methadone, and by after 6 days, the patient had satisfactory or better pain relief, but it was not satisfactory. So we increased it to 2.5 milligram PID. And with that, he had a good pain relief for about 10 days, but then his pain increased. So we again increased the dose of methadone. You can see that we increased dose of methadone only after 7 days, 5 to 7 days, not before that. So this is one thing which you need to understand. And we were very careful. Even we were giving 3.75. These were our early days of using methadone, where we were not very much confident in using methadone. So we continued other medications. And this is another patient who is a 39-year-old woman with carcinoma of the pancreas, stage 4, with liver, lung, and spleen mets. She received 5 cycles of chemotherapy. But then oncologist assessed the patient and saw that disease is not responding. So he asked to stop chemotherapy. And she was receiving palliative care from the oncologist itself. But her main problem was pain. You can see the distribution of pain. And pain score is 8 by 10, which increases to 10 by 10. She says it is stabbing type of pain. And the relief is with morphine, tramadol, and paracetamol. When you give these together, 3 medications together, her pain reduces to 8 by 10 from 10 by 10. She was unable to sleep. She was very much depressed, and she was very sad. So these were the medications she was getting from that oncologist. Tab morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV TID, injection paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisoprolol 5 milligram 2 HS. Anybody has any comments on this prescription?
Morphine and tramadol should not be given together. And also when there is myoclonus, tramadol should be avoided.
Okay. Yeah. One is potent and the other one is weak opioid. So need not combine both tramadol along with morphine. Instead, you can increase the dose of morphine. Okay. So this is a patient whom we can start on methadone.
Yes, we can.
What are the indications?
Opioid toxicity, myoclonus.
Yeah, this patient has opioid toxicity. That's right.
Yeah, see, opioid-induced neurotoxicity.
Yeah. And poor
Unrelieved pain.
Yeah, unrelieved pain with other opioids. Yeah. Anything else? From the description and the site of pain. What are the other indication? Maybe neuropathic also. So these are the 3 components which this patient can be started on methadone. So do we need to do any investigations? I told you that investigations should be depending on the goals of care of the patient. What is the goals of care in this patient? Is it comfort care or is it curative treatment? What do you think? Anybody?
Comfort care.
Yeah, this patient has stage 4 malignancy and the oncologist stopped chemotherapy because the disease is not progressive. So all the care now or the goals of care now change from curative to comfort care. So do we need to do any investigation in this patient actually? Not needed. But the other patient, even the other patient was also a candidate who did not do any investigation. So we already told this. And what would be the dose of methadone in this patient? Can you calculate? No. What is the total oral morphine equivalent she is taking? Please calculate. I'll give you 2 minutes.
So 8 by 10, 80 by 10, 8, 10:1. Methadone 88, 10 milligram per day.
Okay. Any other answers?
So most are 8 milligram per day.
Okay. Okay, let's see. What should be the dose of methadone? So as you told, the dose of morphine, she is taking 20 milligram 6 hours. So that will come to 8 milligram, 80 milligram. But you forgot that she is also taking a tramadol, which also you need to convert into equivalent or oral morphine dosage. Okay. So what is the oral morphine equivalent of tramadol? It is 1 by 10 plus potent. So she is taking 300 milligram of tramadol per day. So you have to divide it by 10 because it is the potency compared to morphine. So the equivalent of tramadol, oral, the oral morphine equivalent of tramadol is 30 milligram. So you have to add both 80 and 30. That will come to 110 milligram. And the patient is young, 39-year-old, and the oral morphine equivalent is between 60 to 199. The conversion ratio will be 10:1. So the total dose required would be 110 divided by 10. That is 11 milligram of methadone. So maybe you can start with 5 milligram daily methadone. So this patient, do you have any concern with any of these medications?
So there
Maybe
is a
Amit,
response,
yeah.
stop tramadol and amitriptyline.
Okay. Yeah, amitriptyline has a problem here because it can. We know that when methadone is co-administered with SSRIs or any TCAs like amitriptyline, it can actually increase the serotonin levels. But that's all are very rare actually. So in this patient, we actually didn't make any changes. So this patient was came to us maybe after 2 years that we have first started methadone. So we were confident enough not to stop amitriptyline in this patient. So we continued with amitriptyline and gabapentin. Just added 5 milligram of methadone along with morphine 20 milligram Q-cortisol and SOS cases. This patient had very good pain relief for almost 2 months and then she died. So this is another patient, 40-year-old man with advanced malignancy of the lung. He complains of pain on both lower limbs and he has a T12 compression fracture due to metastasis. Complains of bailing pain, which is continuous in nature, and it's on oral morphine 40 milligram Q4H and SOS. So this patient, suppose you want to convert this patient to methadone, what would be the dose of methadone and what would be the conversion ratio? Anybody can tell me? Please calculate and tell me what should be the
Yeah,
dose of methadone.
20:1, 5 milligram TID.
Okay. So let's see. So this patient is receiving morphine 40 milligram 4 hourly. That means 40 into 6, that is 240 milligram of oral morphine. This is the total morphine he is consuming. So what should be the conversion factor? If the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years, the conversion ratio should be 20:1. So the conversion ratio here is 20. So 240 divided by 12, that will be 12 milligram of methadone. So maybe you can give syrup methadone 5 milligram BD or even 6 milligram BD. So this is how you need to calculate the dose of methadone. And you have to continue morphine on a 4-hourly SOS basis. And if you look at these websites, you will get medications which can interact with methadone and medications which can also cause QT interval prolongation. So in short, methadone, even though it has some serious side effects, especially when you use in higher doses, like patients who are on substitution therapy, hundreds of milligrams, it can produce side effects. But here, in the context of pain, we are using usually less than 40 milligram of methadone per day, and it is not going to produce torsade points or sudden death. So I think we can actually use a methadone safely if you stick to the basic principles. Don't increase the dose of methadone before 5 to 7 days. It will take 5 to 7 days for stabilizing the blood level. Then you need to have a reliable caregiver for starting a patient on methadone. And when you start methadone for the first time, you will have many confusions, which we also had. Then you have to seek the help of somebody who's experienced with methadone. So just keep it in mind and don't hesitate to approach anybody if you are going to start methadone on any patient for the first time. Once maybe after a few patients, you will be more confident. Always think of the medications that can cause interactions with methadone, because methadone is metabolized in liver, and many medications can either decrease or increase the level of methadone. And we also talked about acronym GFATMAN and the PS box. And also keep in mind which are the patients who are suitable to start on methadone. So if you are not confident, maybe you can start methadone as an adjunct. Use a small dose at night for patients who doesn't have proper pain relief at night. Maybe 2.5 milligram, 1 to 2.5 milligram at night. Then there are various indications in which you can use methadone. So thank you. I think I will stop here.
We can have a few questions if you have any questions in methadone. Is there anyone in this group who are using methadone in your setting for pain management?
Yeah, we are having oral methadone syrup.
You are from Orissa, right, sir? AIIMS
Yeah, AIIMS Bhubaneswar. Yeah, that's right, ma'am.
Methadone is available, and you can use your RMI license to get methadone. You need not have any other license.
Yes, Dr. Shilpa. Please. You are muted, ma'am.
Okay. Ma'am, my question is related to morphine. In one of the prescription, it was written tablet morphine was given like 10, 15 and 10, 30. So,
Yeah.
so
Yeah.
sir, can you please explain that?
Okay. So that was not, I told you, that was the patient who came from another center.
Okay.
And they have tried the patient on injection morphine, and he had a toxicity. So I think they adjusted the
That is
dose of morphine in a fine manner. That's why they put him on such 10, 15
okay.
like that. And that was even not 4 hours. So that your
Yeah.
observation was correct.
Okay. So one more thing, when we are giving 4 hourly morphine, so is it not like the nighttime dose is like same, or is it to be doubled?
Morphine is usually given a double at night, a double dose at night.
So in that way, sir, the last patient where the morphine equivalent was to be calculated, that just created the doubt in me. So in that case, if it was 40 milligram 4 hourly, then the nighttime should have been doubled. So is it like total dose should have been 280 milligrams, I guess?
Okay. So that means 40 milligram Q per hourly means usually you give double dose at night at 10 p.m. and you will not give any morphine thereafter if you give double dose at night. But if you
Yeah.
give every 4 hourly, that means at 10 p.m. you will give regular dose, at 2 a.m. you will give a regular dose. So the total
Okay.
doses will be 6.
Okay.
And anything in addition will be extra dose or extra dose.
Okay. Thank you, sir.
Anyone
Sir,
else?
there was one thing in the last. Hello, am I audible?
Sorry, your voice is echoing. We can't hear anything.
Okay, can I write it in the chat box?
Yes, please.
Yeah. I think you have logged in from 2 devices. That's why I call.
So meanwhile, I had a question to ask to Dr. Sunil. So if we are giving methadone, if we are starting a patient on methadone, and the patient is receiving other adjuvants like say amitriptyline or pregabalin or gabapentin, so do we continue with those adjuvants or we sort of stop them?
It actually depends on the condition at which the patient presents. Suppose if you think maybe fail and you think there will be chance of high interaction, then maybe you can reduce the dose of amitriptyline because you will not be able to stop it suddenly. So maybe if he was on 75 milligram, you may reduce it to 25 milligram because methadone also has the same action, tricyclic antidepressant like action. But if a stable patient, I think we can continue with methadone along with tricyclic antidepressants or
Sir, cost of methadone is one question.
Cost of methadone is actually it is very much similar to morphine. So if you look at morphine, 10 milligram, suppose 30 milligram, 5 milligram every 4 hours. That means 30 milligram. So 30 milligram tablets cost about 4 rupees 10 or 4 rupees 50 paise. And the methadone also costs maybe if you give 2.5 milligram daily, it will be about 5 rupees or 4 to 5 rupees. So the cost is comparable to morphine. It is not like the fentanyl or buprenorphine, which is very costly.
So Dr. Ariba has typed her question in the chat. The last case, the total morphine dose was 240 milligram. That is more than 200, but the age was less than 60. So the conversion factor is 1:20 is one question she has asked.
Yeah. Either the patient is taking more than 200 milligram of morphine, or the patient is 65 years old. Suppose this patient was taking maybe 180 milligram of morphine, and the patient is 65. Then again, the conversion ratio would be 20:1 because the patient is 65 years old.
Yes, Dr. Shrikant, please. Sir, you're muted.
So you had mentioned the last case of that of a paraplegic. How long would you continue methadone for in such cases? Because they will have pretty long life expectancies, at least if bladder is managed.
Patient, okay, I think that patient was having malignancy, CA lung with.
Correct. Sure.
Yeah. But when you use opioids for patients who doesn't have cancer, then you have to be very careful because the chance of getting psychological dependence is small. So first of all, you have to use, you have to ensure that you have optimized the non-pharmacological therapies, and then you step on to non-opioid plus adjuncts, and then to weak opioids, and then only last you will go to third step with morphine or anything, any other strong opioids. But you have to also assess the patient for opioid use disorder. There are various instruments available, and one such instrument is opioid risk group, or RP, which will ask you. Actually, the patient needs to fill it up, which has age of the patient, any history of psychiatric disorders, family history of psychiatric disorder, any history of smoking, drinking, like 5 or 6 questions only. And there are scores given to that, and you can categorize the patient into low risk, medium risk, and severe risk. And you have to actually monitor this patient depending on the risk category.
So there was a question on the maximum dose of methadone per day, and Dr. Ariba has responded to that as not more than 40.
Yeah, this is the usual dose, not more than 40 milligram. But I have seen that some doctors, even from the MD Anderson Cancer Center, they have even used, I think, up to 800 milligram of methadone in a lady who had a very severe pain. But I think our maximum dose was 42.5 or 45. And that also very recently we had a patient. So we try to increase up to 45 milligram in that patient. But usually it is less than 40 milligram.
Are there any other questions before we wind up today's session? I think if there are no other questions, I think we will be winding up the whole session, not just today's. Sorry?
I have a question, ma'am.
Yes, please.
To the participants, I need feedbacks. I had already intimated in the group that we are open to feedbacks after the session about the entire course. Like, I would also request Sunil sir to stay back if possible, so that he also gets an idea about the entire course and how the entire things work out. So
yeah, specifically on something that we need to improve. other than the assignments.
Dr. Vikram, yes, we are working on that. We will be sharing the results as soon as we get it from the faculty. But apart from that, maybe about the entire syllabus. Yes, Dr. Vikram, yes, definitely. Each and every eligible participant will be getting the certificates as soon as possible. We are definitely working on timelines.
Yeah, we are
Apart
moving towards the automatic certificate generation, but we are on the process. But till then, it is manual. So literally, they are sitting with the assignments, getting it back from the faculty. So everything is manual. That's why the delay. But we understood that from the last few batches, and we are moving on to the. So once you finish the assignment, we'll be having a website for learning management system where you can just get the certificate once you are eligible. So that will happen soon, but unfortunately, if not for this batch, these people have to sit and do it. Yeah, there are more feedbacks coming. That's something that we were really looking forward to. More case scenarios and discussions. For children, yes. Children's palliative care should be a separate course itself because it has all these sessions have to have a pediatric version too. So that should be another course which is currently not there with us. I think the conversion of different analgesics need more practical scenarios and case-based discussions.
So I see another comment, any advanced course being offered by palliative. So
yes.
There are a few courses offered by us. One is refresher course in palliative medicine, which we already did one course. I think
the next one will be in June, Dr. Sunil. It will be hopefully we will be sharing as soon as we announce the dates. We'll be sharing that in all the WhatsApp groups. So just don't exit from the WhatsApp group. We'll be posting all the updates, and we have specialist specific courses also. Right now, we are doing a course for pulmonologists, which will be focusing more on the respiratory symptoms and the issues in the ICU, withdrawal, withholding life support, specifically in.
Dr.
Yes,
Ravi Kiran, yes, we are planning to have a fellowship course in palliative medicine, probably in another 3-4 months. We are planning to start. So it's the materials are getting ready. So probably we are going to start in another 3-4 months.
All the upcoming course or any academic programs we will be updating in the WhatsApp group. So, and if you have anything that during the patient consultation that you would like to discuss with us, you can use our telehealth helpline, or you can WhatsApp in the group. We'll be, as soon as we see the queries, we try to get back to you. Or you can directly call the telehealth number and ask for inputs from them. And there are a few programs like small group mentoring program where there will be 5 or 10 participants with live patient or the real patient discussion with one mentor. So that will be a more personalized session, not based on topics, but purely based on the patient that you are seeing. So all these programs are there, and we'll keep updating or sharing the information in the faculty, the group, WhatsApp group. Sri Priya?
Yes, ma'am. Okay.
I think that's all from my side. I'm so glad to be a part of this program. This was very interactive. And when you ask questions, we also learn a lot of things. And your setting, we'll understand more about where you are coming, this group was like very different backgrounds, like right from the critical care to the people working in the community. So it was an amazing journey for me personally, because from the questions you were asked. And it was a very, very interactive group. I have to admit that it was a very interactive group. I don't think any of the sessions lacked interaction from your side. So thank you so much for making it so interactive. Sri Priya.
Thank you, ma'am. Thank you so much. Special thanks to each and every participant over here who made this journey eventful, because we were also excited when we started this particular cohort, because this was, as you know, the 100th program of our ECHO Pallium team. So we were also excited, and true to its words, this was an, as Sridevi ma'am rightly said, and diverse group. So before we wind up, like anyone would like to unmute?
I would like to tell one more thing. If anyone is interested to write any testimonial, like we have experiences of people telling we used this particular learning on this particular patient, and this is what we have understood or we felt. So any testimonials from your side will be really, really encouraging for us. So we expect to get, if you are interested and if you are okay to publish it in our blogs and social medias, please feel free to write to us. Sorry, please carry on, Sripriya.
So anyone would like to just unmute and say a few words, because of course we are getting many responses in the chat, but still anyone would like to unmute and say a few words? Thank you, Dr. Shweta. Looking forward for that. Okay. So
I just wanted to take the opportunity to thank all of you, and literally you have held our hands and moved us through these wonderful 1.5 months. And every class was very refreshing and eye-opening, and definitely it has helped us improve our management of these patients, because they come with a lot of complex issues, and polypharmacy is the least of them. But how to go about the management, how to deal with the patients, and the little things beyond the pharmacological treatment, all these things I think definitely would be going a long way in improving the care of such patients. And thanks to Pallium India for handholding each one of us and taking us through these wonderful sessions. Thanks to the infinite patience that you have shown with all of us, addressing our queries all the time, and being there for us throughout this entire course. Thanks to each one of you.
thank you, Dr. Satyajit. So, as a person coming from a non-medical background, of course, I don't know even one word of what the medical terms you all were talking, but the interest and the passion with which all the participants were responding, they were participating, gives me the hope as a common man that we are handing over the baton of palliative care to the right persons who could take it forward in their areas, where they will provide the comfort care always as required to the needy people. So wishing that may the Almighty be with us, everyone over here, to spread the comfort care which the people need around us. This is Sri Priya, along with Dr. Sridevi Warrior and Dr. Sunil Kumar, signing off from the Tips Eco Hub. We'll be in touch through the WhatsApp group. Stay safe, stay happy, spread happiness. Take care, everyone. Bye-bye.